Hey everyone, I'm John Lynn, the founder and chief editor at Healthcare IT Today. We're excited to bring you another in our series of interviews with top leaders in health IT. And today's guest is someone that I think most of our community knows quite well. It's Micky Tripathi. He's National Coordinator for Health IT at HHS. Welcome, Micky.
Thanks, John. Really delighted to be here.
Yeah, glad to have you back on the program. Although I think it's the first time we've had you since you took over as national coordinator. So excited to have this discussion. But for those that don't know about you, tell us a little bit about yourself.
Sure. Yeah, I think it was just before maybe I'd made the switch. So I've been in this role since President Biden came in. I was a day one, hour one start. So I started like 1 minute after noon on January 20th, 2021, as the U.S. Constitution prescribes. And prior to that, I was working at Arcadia as for roughly a year, and then prior to that, I ran an organization, a nonprofit organization called the Massachusetts Health Collaborative. So for about 20 years, I've been involved in health IT, electronic health records, and the policy issues related to that, technical as well as the policy issues related to that.
Yeah, absolutely. They should go check out our previous interview to hear some of that history. It was fun to go back and kind of relive some of that, the early EHR days, and oh yeah, we got to set up an internet.
Right. Yeah.
Anyway, go check out that video.
Hard to even put yourself back to those times.
Yeah, do we want to go back to that? I don't know. Not really. Anyway, I'd love to hear your thoughts because you're so deep into health IT, to interoperability, to the policies, regulations, et cetera. How would you describe the state of electronic health information sharing and kind of interoperability as it stands today?
I guess I would describe it as, about to make great leaps and bounds forward, that we're just getting started, but we're starting to approach, sort of the hockey stick of data exchange in all of the different ways that, that data can be exchanged in ways that'll start to, sort of more closely mimic the kinds of information sharing that's, happening in other sectors. And, the reason I say that is because, we're now at the point where, 97% of hospitals and 90% of ambulatory providers have well-functioning, we can talk about whether it's well-functioning or not, but certified electronic health record systems that have the capability of capturing data and, communicating that data. And that's a real threshold moment for us that, it was a lot of hard work to build that foundation and to lay it down. But now we're at the point that we're starting to be able to, sort of take advantage of that in a good way, mostly, and be able to start to think about what are the kinds of things that we want to be able to do with that. Which I think is, the really exciting part of where we are today, and why I'm really excited about being in this role at this particular time.
Yeah, from an interoperability perspective, any EHR is more effective than paper, I think.
Right.
So,
yeah. And I think, one of the things that we just have to recognize is, we were trying to do a lot with interoperability, me included, back in, we're building health information exchanges and all of that. And just recognizing that, most providers didn't have electronic health records then. So, that's a big barrier to be to having interoperability if, most people actually don't have electronic data sources. So that's why I say, we're in a very different position today. And now we have that opportunity to really reframe the way we're thinking about things to say, well, now that we're digitally native, how do we, sort of recreate, sort of the world that, in a way that's hopefully starts to be less and less, kind of tethered in the, sort of the mental models of, and the real workflow models and business processes of paper, bricks and mortar to things that, really are more digitally native.
Yeah. I mean, it's interesting to think about the shift at ONC. There must have been a big mindset shift because in the beginning, it was like, how do we dispense this $36 billion of electronic health record stimulus money? Now, like you said, it's I don't know if it's done, but, like at least it's implemented to your point. But, and then I think the other big thing that probably is on your mind is the 21st Century Cures Act. Where do you see that act, making an impact for good on patients and clinicians?
Yeah, I think it's huge. I think it's really complementary to all the work that, that was done under the High-Tech Act, which is, as you point out, was, $36 billion of incentives to providers to adopt electronic health records. ONCs, we weren't in charge of $36 billion, which we had been, but we weren't. But we supported CMS, obviously, and we continue to today. So in some ways, the work isn't that different. It's, sort of got a different focus. To the extent that, then it was about electronic health records, getting electronic health records into place. And now it's much more about the use of electronic health records for the public interest and for what's good for our country. And so in some ways, the nature of our work kind of moves up market, and we kind of follow where the market is. And, it's first about electronic health records, getting them in place. And now it's about saying, what are we going to do with the electronic health records? And that's what 21st Century Cures Act is focused on. So when you think about the different pieces of that, the information blocking regulations, which are about the behavior of people who are the custodians of data, the approach to having access to information without special effort was the exact words that were used in the 21st Century Cures Act. And then finally, network level interoperability as reflected in Tefka. All of those pieces that are about saying, all right, let's make the assumption now everyone has electronic health records. Now, what are we going to do with them, and how do we ensure that those electronic health records are used for the higher level purposes that that were a part of the vision of the High-Tech Act, and are now sort of more firmly instantiated in the 21st Century Cures Act.
Mm-hmm. Do you think healthcare organizations have kind of woken up to the information blocking and the other pieces of the Cures Act? I feel like there's kind of a change in mindset that they kind of saying, yeah, well, patients need this, otherwise, like, that could be a problem for me. Although I think there's some that are dragging their feet a little. How do you see it? Is it really going to create this sea change in the healthcare organizations, or is it going to be a process? What perspective do you have on that?
Yeah, I think that it's an added impetus and perhaps a backstop to changes that were already taking place in healthcare. I think that there was growing opening up of exchange practices that was already happening. So, the 21st Century Cures Act was passed in 2016, a long time ago. And already, I think we were starting to see nationwide networks form. We were starting to see a lot more sharing of information that was already happening, partly because of things that were driven by things like value-based care. That was, that hasn't, taken over the market, but there was enough there that there were enough organizations who were participating in it, and were seeing that interoperability was a business need as they were entering CMS, MSSP contracts, and other kinds of things, looking at the CMMI models that were coming out, and then of course on the commercial side, the commercial plans sort of following suit and having their own interoperability requirements related to value-based purchasing. So I think that was happening. I think that increasingly that information sharing is increasingly seen as a standard of care, among a larger and larger fraction of providers. That my daughter's a physician, and I think it's quite natural for her to think, I'm going to get the best information I can, and I'm going to be sending information to other parties, and I'm not going to. No reason for me to be proprietary about this stuff. That's the way. It's the mindset of of the transparency that we've seen in almost every other sector of the economy, and generationally. I think that there is a whole younger generation that's entering the picture that has a different view of this. I think the pandemic also is certainly a driver of understanding the need for for information sharing. So I think all of those are things that were propelling the market in that direction. But certainly I think 21st Century Cures Act, as I said, is like an added impetus, perhaps a catalyst, because you start to instantiate it in regulation and people start to pay more attention to it. And it's a little bit of a backstop for those who, as you point out, are more recalcitrant, let's say, about sort of understanding the direction of all of this and the need to do it. That allows us to be able to say, hey, everyone needs to do this, and this is a floor that all of you need to to be able to get to, and hopefully do a whole bunch more on top of that. So I think all of those things, I think, was a trend that was already happened, but certainly the 21st Century Cures Act adds impetus to it and helps to catalyze it.
Yeah, it's interesting how we all want all the information, but we don't want to share. Like, yet we
Right.
want to benefit from having it. So
Yeah.
it was a change
And
of
you
mind.
know, I mean, I'll say that in my experience, and this is just, my experience, that a lot of that was, there's certainly, bad actors who want to data hoard for competitive and proprietary reasons. I'm not saying that that doesn't exist, but in my experience, there's a lot of it is about priorities and is about provider organizations and others who have a ton on their plate, and in the list of priorities that they have, it's real work to share information, right? You have to change your compliance policies. You got to deal with your compliance officer. You got to work with the interoperability mechanisms of building those capabilities to make that information available. And then you have to work with all your end users and workflows to sort of say, no, do it this way. Don't fax it. Here are the circumstances in which you do it. Kind of doing all of that is really hard work. And at any given time, you talk to a CIO in a hospital, it's like, well, I got cybersecurity, I've got, quality of care, I got safety issues, I got all of these things that, that are just higher on the priority list. And so, at least in my experience, again, there were certainly and still are organizations that are doing it for their own competitive reasons, but there are a lot of provider organizations and other organizations for whom it just wasn't a priority given all the things on their plate. And now one of the things that we're saying with the 21st Century Cures Act and the succeeding rules is you need to move it up the priority list. That's what you need to do. If it's not a high enough priority for you, we'll help you move that up the priority list to make it a priority.
Yeah, those penalties or other incentives, can help with that. That's a really interesting way to look at it. Are there things or pieces of the 21st Century Cures Act that, are what would you say is the most misunderstood part of the Cures Act?
No, that's a great question. I think certainly there were different dimensions to it. So I guess one of the misunderstood pieces is that, that with the wave of a wand, all of this information will now be free. You may have seen that, on October 6th, when the full scope of what was required to be made available went into effect on October 6th of this year, a number of publications called it Data Liberation Day. Which is great. I mean, I was very happy with that. Don't get me wrong. But I think that, I think what's probably not as well understood is how complex that is. That that if you go into so if you go into a hospital setting, and I'm not talking about Johns Hopkins or Mass General or Mayo Clinic, go to a community hospital, and you'll see that they've got their electronic health record, Meditech, Cerner, CSPI or Evident, I think they're called now, Epic, whatever it is, and then they've got a whole bunch of other ancillary systems, and each of them has a different constellation of systems based on their history and their legacy and which departments they have and which specialty they support and what their patient population is and all of that. And the complexity of our saying starting on October 6th, all of that information needs to be made available in shareable and machine readable format. That's really complex. It's complex on a number of different dimensions. One is we ourselves, meaning the federal government, through the HITECH Act and everything, we kind of train providers to rely a lot on their EHR vendors, right? Where we basically said, you'll get these incentives, and don't worry, ONC is going to certify the EHR for you so that you actually have some confidence that the EHR will actually allow you to do the things that will allow you to get your incentive dollars. And the vendors, I think, did a lot of work in actually educating providers, right? They would provide a lot of education to providers because they had the staff to follow the regulations closely. So they were able to sort of work with the providers to say, no, here's what this rule means and here's how it's implemented and all of that. One of the challenges with it's a good problem to have is that with 21st Century Cures Act, it says it's not exclusively about what's in an EHR. It's actually all this other stuff as I was describing. So your natural tendency, if you're a CIO of a hospital, let's say, might be to say, let me talk to Cerner, let me talk to Epic, let me talk to my EHR vendor who has been my partner in this and has helped inform me. And they can help to say, here's how it works in our EHR. But by the way, you have these other 23 systems that we don't even touch. we're not even, we barely know what those systems are. And that's going to be your responsibility, provider, to figure out how to get, all those diagnostic systems and that anesthesiology system and that ED system and that chemo dosing system that may be 10 years old and, and can spit out a fax line and, nothing else or something, whatever it is. I think that's a real complexity that we all just need to appreciate.
Yeah.
And that's, and so I think that there's that part of it. I think the other part is that, is a little bit, and this is a little bit more maybe on the provider side, is not understanding that we built exclusions into the rules for good reasons. That we recognize that on the one hand, there is a requirement to share the information, and we believe that people need to flip their default mode from I'm not going to share information until you give me a good reason to I'm not going to stop the sharing of information unless I have a good reason. But we listed and laid out those good reasons, and because those are legitimate reasons. If your system, that weird esoteric diagnostic system, for example, that absolutely has patient data that patients have a right to be able to get, if that's like a 15-year-old system that literally you cannot get an electronic feed out of, it is okay to say, I can't do that. It isn't feasible. There's an infeasibility exception for that reason. There's a harm exception. If you as a provider feel like my patient will actually be harmed if I release that information directly to them. I never would have done it in the paper world. So, so I shouldn't be expected to do it in an electronic world. Those are all things that, that are accounted for in the exclusions. And I think providers, and maybe that's, partly our fault. I think providers don't have a good enough understanding that those are there to help them navigate through this process.
Yeah, I think you triggered a little trauma of the old medical manager Unix box under the HIM desk when I implemented an EHR 16, 17 years ago.
Right. Yeah, absolutely.
Yeah, and hopefully there's no more under the desk at HIM. I think we've learned that, but everyone has those old systems, which we have to for legal reasons, retain them. Very interesting. You may have already answered this, but maybe I'd love to hear if there's something else as well. Are there other areas of the Cures Act that you think are going to be the hardest for healthcare organizations to implement? What you said makes sense, having that many systems. I think your number of 23 is low. It's hundreds, sometimes thousands, which is just astounding. And we know that because whenever there's a merger and acquisition, they have to deal with it. And so then they're like, oh, wait, we have how many systems? So that was obviously a great example. Are there other areas that you think are going to be hard for healthcare organizations and they should maybe put some added focus on?
Yeah, I think that, certainly everything we were just talking about from a technical perspective is that, that's challenging. Taking an inventory of all of that stuff, figuring out how you're going to surface the data in each of these, things like just patient matching across all those systems and linking, right? That in and of itself is a challenge. When you talk to organizations, I think, Aaron Meary, who's, the CIO of a hospital system in Florida, has talked about this at the High Tech Act, how much time they've devoted, and they are continuing to vote to just that problem. Where is our EHI, which is, so first off, maybe I should step back for a second. Defining what is EHI, what we've tried to do is be helpful to providers to say, EHI is just the electronic portion of the HIPAA designated record set, which you since 2000, since the HIPAA privacy rule and the HIPAA security rules came out, you were required to maintain that designated record set. That's what your medical records department gives to a patient when a patient comes in through a right of access and says, I want all my records. If any patient who did that, you would give them the designated record set, the data that's in there. And so we thought, all right, well, let's build a rule on that and just say, well, it's the electronic piece of that is EHI. Well, it turns out providers, still often don't have a good operational definition of the designated record set, and therefore figuring out the electronic portion isn't, quite as straightforward as one might imagine. And the fact that HIPAA says that is a local determination. So Mayo Clinic has a different definition of the designated record set, let's say, than Mass General Hospital, then Springfield Hospital, then, Bay State Hospital. So you've got, that inherent complexity, which is just figuring out in my organization, what is EHI? And then the technical part that we've already talked about. I think the other part is that this is intended to be a real change in mindset. And a change in mindset means that you've got to change your policies. And that means that, you've got to look at all your policy documents. You've got to work with your compliance officers. You've got to work with your HIPAA lawyers, and your information blocking lawyers, to sort of say, what about our policies do we actually need to change? How do we work on that policy change? How does that translate into all the forms we have? How does that change into the training we give to the providers at the front end? How do we make sure that we're communicating properly to patients, so that, we may have the policy, but all it takes is a provider or, someone in the medical records department to say the wrong thing to a patient, to say, oh, no, you can't do that. Or, oh, we're not going to give that to you for 30 days, or you need to pay, for all of those things. All it would take is that one kind of mistake, and that could lead to an information blocking complaint. And, a valid one from the extent that that was the patient experience, but it may be that the organization's policy actually isn't that. It's just that frontline person didn't know because they've had 20 years of experience doing it a particular way. And so if you don't have that training all the way down to the, to the frontline people, I think that that's, going to be a real big part of it. And I think that that's underappreciated, how much work that is. And, to people who say, wow, that's a lot of work. It's like, well, read the 21st Century Cures Act. That is the law of the land. If you read that and don't come away thinking, wow, the Congress and the president really want things to change, then I think, you're not doing a good reading of it, because that was really the subtext of it.
Well, I think all the HIM professionals out there are cheering you on, because they've been trying for years to get that designated record set set
Fine,
up.
right? Yeah.
Nobody cared, or not all. Some
Right.
organizations did a good job, but they were fighting a tough battle, and now they have a little more teeth behind it. So I think
Right.
that's good.
We'll call it the HIM Department Empowerment Rule.
You should. They would love it, and they could be a help to this. I think IT
Absolutely.
forget about that, right? They often know where the records are because they're doing the release of informations, et cetera. So I think it makes sense.
Yeah, I will say, one added thing to that in terms of the complexity. We talk a lot to provider organizations, and there's certainly a lot of challenges that frontline providers are facing. And just the point I was making about training, one of the things that that I feel like I've heard is when I talk to a lot of providers and hear about what they're talking about and the challenges they face, the first thing that comes to mind is, wow, your organization did not prepare you for this. Here you are in a hospital system, you're at the front line delivering care and sharing information and in the EHR, and your hospital did not train you. They did not tell you about what was going on here. And, so how much of this is about the policy and how much of it is really the failure of the organization that didn't empower the physicians who are at the front line to have the best available information so that they could respond appropriately and have the enough lead time to be able to do what they were, what they needed to do. So in some sense, the physicians are the ones who got caught in the middle in many cases, at least, from things that I've heard.
Well, the doctors read their emails so well, but no, it's a marketing task.
Doctors get a lot of emails.
Yeah, so let's shift gears a little bit. Let's talk about everyone's favorite new words, Tefka and QHINs. What should people be keeping an eye on when it comes to Tefka and QHINs? And I'll admit, when I first saw Tefka, I was like, who cares? There's no teeth. But then I saw QHINs and I'm like, oh, that's a big change. So talk to people about what should they be watching to understand what's happening with Tefka and QHINs.
Yep, absolutely. So there's been a lot of work over a relatively short period of time. When we came in 2021, there'd been some work, but it was kind of hidden a lot from the public, and there hadn't been a whole lot of progress over the years since the passage of the 21st Century Cures Act and in 2016, and release of sort of a first version that that had kind of stalled a little bit. So we looked really hard at it to first, ask ourselves, is this needed? Is this something that's going to offer value? And if not, then, maybe we should, say, what, the best use of taxpayer dollars here is to not move forward or to significantly pare down, what the approach is. But we looked really hard at it and said, there's really tremendous value that could be offered here, that to get the where we are with network interoperability to the next level. And the next level requires public-private partnership. That up until now, almost all the activity has been private sector activity, and it's been great, right? I was very much a part of it. I think, as you know, from the probably from the previous interview that we did. I think we probably talked a lot about that. That what Care Equality and Commonwealth and eHealth Exchange and number of state HIEs have done has been tremendous, and it's gotten us to a lot of interoperability among providers. Certainly a lot more to do, but I think that given that it was a private sector activity that required collaboration and voluntary participation and people investing their own money to do this, I think that that we've seen a lot of progress there. But as we look to say, well, what's the next level of things that we want to be able to do? Is not just provider to provider exchange for treatment purposes and better implementation. That's where you start to say, that's where Tefka and the public piece of this can start to come to the fore and help the private sector, sort of move this up to the next levels where the private sector can't on its own. So things, back to your question, things to look for. We are in the process now of, and by we, I mean the Sequoia Project, who is our nonprofit partner in this. So it is a true public-private relationship where ONC and the Department of Health and Human Services defines kind of the big policy box that says, here is the policy goals, and here is the things that we want to accomplish from a public interest perspective and from a federal government perspective, and then allows operational leeway to the RCE to be able to do the implementation of that, but all with that ongoing guidance and ongoing oversight from ONC and the Department of Health and Human Services to ensure that that we're not delegating away a real government responsibility here, which is to make sure that we have network interoperability in the public interest. And so so now we've the applications have been out for prospective QHINs, qualified networks, who want to apply to become designated as QHINs. That happened in September. There are now 12 organizations that have submitted letters of intent expressing their intent to apply. There are a number of organizations who've actually submitted their applications, their complete applications. And now the Sequoia Project is reviewing those. And we are going to be having an event. So the next thing to look for is that we will be having an event in early 2023 that the Department of Health and Human Services will be announcing the waving someone. The Department of Health and Human Services will be announcing the first QHINs or prospective QHINs that have made it through the first big step, which is that their applications have been approved, meaning they've met the eligibility requirements, because there is a pretty high bar that we're placing on this, because we recognize this is like nationally critical infrastructure that we're talking about here. And for anyone who doesn't believe that, just think about the pandemic and think about what we want to be able to accomplish from an interoperability perspective. And then you start to say, okay, yes, this is nationally critical infrastructure. So they will have made it through that process, and they will be signing the common agreement, which is the common contract, the common rules of the road that they are agreeing to. So that event will be in early 2023. As I said, it will be the Department of Health and Human Services, as well as the Sequoia Project, announcing those first QHINs that have gotten through that very first, the first but very important stage. And then that will set the, set the timeline for them to go live within 12 months, which is what they're required to do. And so they'll go through testing, and then they become fully designated because they have to meet, certain requirements related to their technical capabilities and their capacity. And then they will be designated as QHINs. So next thing to look for is that announcement, and then look for the implementation. And the other thing I should add is there are going to be pilots, fire exchange pilots that are going on in parallel, because one of the things that the Tefka didn't include when we inherited it was completely silent on fire. Which to us was a glaring gap. So we very specifically included fire-based exchange as a part of what Tefka will support. And so we're organizing now, and we'll be launching fire pilots in early 2023 as well. And those fire pilots will then sort of iron out the wrinkles in fire-based exchange, with an eye towards saying that fire will become a part of the full production capabilities of Tefka-based exchange in 2024.
And if I'm a provider organization, just to circle back on kind of the previous comments,
yep,
I'm probably going to rely on my EHR vendor or my HIE vendor for the QHIN exchange, right?
Sure.
Okay.
Yeah, I mean, I think for the most part, absolutely. I mean, they're allowed to do it in any way, but we've gotten tremendous participation and interest from the EHR vendors supporting their customers, and and for most EHR vendors, that's because they anticipate that their customers are going to be demanding it. That's why they're doing it. So if you look at the organizations that have already publicly announced that they intend to become QHINs, some of them are EHR vendors like NextGen, like Epic. And then a number of them, like the Commonwealth Health Alliance, which is publicly announced that they are going to be applying. They are made up of largely of EHR vendors, Meditech and Athena Health and eClinicalWorks and a number of them and provider organizations. So they certainly are directly participating and have expressed a lot of interest. And again, I think we live in a market economy, so they're doing it because they think that their customers are going to be demanding it of them.
Yeah, absolutely. So as we kind of wrap up here, I'd love to hear, what is your overarching vision for ONC? As the leader of ONC, what's your vision, and how does all of this stuff we've talked about kind of fit into that vision?
Yeah, the overall vision to me is for us to continue to be that organization that helps the market and helps our federal agency partners keep driving toward that open architecture health IT ecosystem that we all want. And in some ways to put ourselves out of a job, which is to say that people stop thinking about technology, right? When I buy a phone, this is my government issued phone. When I buy a phone with my own money, I don't think about, right? I think about what are the functions and how does it work for me and what's the price? I don't think about what is the technology underlying this. And I don't worry about, the fact that this is a Verizon phone. And I won't be able to talk to, the person who's on AT&T. So, the goal and the ongoing goal, and maybe it's, sort of something that we asymptotically approach, right? That perfection, the platonic ideal of interoperability, because, no industry has perfect interoperability, as we know. But, that we continue to be that organization that people look to for help with figuring out these problems, that we are a facilitating organization that's a problem-solving organization, helping people solve the problems related to health IT and interoperability, so that they can better accomplish their missions, and that we are an enabler of that, both, as I said, with our market collaborators as well as with our federal agency partners.
Awesome. Well, Micky, I appreciate you taking the time to talk with us and be back on the program again. I always love learning from you and hearing what's happening at ONC. So thanks so much. And thanks everyone for watching and listening. If you want to find more great healthcare IT content like this, be sure to check it out at healthcareittoday.com or search for Healthcare IT Today on your favorite podcasting application. Thanks, Micky.
Great. Thank you, John. Enjoyed it.